it.
Okay, there is another question in the chat. There's no name. What support is available for family physicians in holding firm against patient and family pressure to push back ahead with the imaging?
So there is, there is a paper which says vomit, right? I don't know if you have seen that.
No, I have not.
Yeah, so it's the don't become a victim of vomit, something like that. I don't remember exactly, but it is there. It's there in some of the pain clinics. We are stuck in the at Jim Pattison. We have that stuck on the wall, and sometimes we take a photocopy of that and give it to the patient. So basically, it says the incidence of degenerative changes that you see in the normal population. So I always spend at least 5-10 minutes telling this to each patient that you take 100 patients in Surrey who are 30-35 years of age, fit and well, healthy, active, playing hockey or whatever, and scan them. You will see degenerative changes. You will see disc bulges. You will see foraminal stenosis, but they don't require any intervention. They don't have any pain. So you have to tell that, and if you can print out that article and show them the evidence, then I think they'll be more convinced.
Shiva, it's victims of modern imaging technology.
Yeah, that's why it's vomit. Yeah,
victims of
medical imaging.
Victims of modern imaging technology.
Yeah,
victims of modern imaging. Thank you. Okay, there is another suggestion, Dr. Humavani. When low back pain persists beyond 68 weeks, patient reassurance becomes even more important with increased pressure for imaging. Otherwise, repeated patient visits to multiple caregivers drives up the health care costs. There is a question from Mosda. When will you recommend rehab like physio, massage, etc.?
So again, you have to make that distinction between different types of, in the spine, obviously there are different pain generators, right? So you have to make the distinction. Is it coming from the facets? Is it coming from the muscles and ligaments, or from, nerve impingement? Massage is only helpful for, myofascial pain. It's not going to help with neuropathic symptoms or facetogenic pain. It's mainly for myofascial pain. So a typical, young patient with no other significant history, despite all the degenerative changes that you see on the X-rays and scans, when you examine them clinically, they have, typical myofascial pain in the paraspinal muscles, and often you can see that in the cervical, thoracic, and lumbar spines. So those are the patients who typically will benefit from massage therapy. But physiotherapy obviously will help all of them. Even facetogenic pain, you would want them to be giving some lubrication to those joints, if you like. So you always advise physiotherapy. Chiropractic manipulation is something that we don't recommend. Certainly not for the neck. But physio, yes, definitely. Physio is really the mainstay.
Thank you. There's another question from Trisha Patidar, the physiotherapist. How often can a patient get an epidural shot? Any protocol on what patient should or shouldn't do after the injection?
So we always advise the patient to be active after spine injections, because it gives them that small window of 2 or 3 months where they can go and do these exercises. So one of the reasons why we offer interventions is to facilitate physiotherapy. So if the patient is in a lot of pain, then obviously they cannot engage with physiotherapy. So one role of injections is actually to help patients engage with physiotherapy. So we always encourage them, and in fact, we patients who are really stuck, we kind of time the injection and we have a discussion with our physiotherapist and make sure they get the appointment, a week after the injection. So they're able to do those exercises better. The question about how many epidurals can be done, the limiting factor really is the cortisone. So if you do frequent cortisone injections, doesn't matter where it goes in your body, because you must remember that many patients get spine injections from us, and then a month later they may go and get a knee joint injection. A month later they may get a shoulder injection, and so on. So it all adds up. So if you do it frequently, you're going to see side effects like weight gain, your glycemic control can be out of this one. You can get immune suppression. You can get adrenal gland suppression. So osteoporosis. So we generally limit injections to a maximum of 4 per year. Most of us, yeah.
There's another question from Laura Kelly. Can either of you speak to current wait times for a lumbar spine MRI, non-emergency, and pain clinic consultation? Wait times.
So the current wait time for Jim Pattison is around 9 months.
For lumbar spine MRI?
No. Pain clinic.
The pain clinic wait time, yeah.
Yeah, I don't work in Ridge Meadows, so I'm not sure about the Ridge Meadows wait line, but it's central booking. So it gets distributed across the lower mainland. And unfortunately, the only MRIs at this time in our part of the valley is only in Ridge Meadows and Langley. Abbotsford, we are working out of a trailer and we are only doing urgent inpatient MRIs. And then the other scanner in Abbotsford is an older scanner. And we are limited again in what we can do there, and also significant technologist shortage. So between technologist shortages and machine shortages, MR wait times are pretty bad. I'm not even sure what the lumbar spine wait times are these days. Probably 12 to 16 months, I would guess. You can get in for a lumbar spine CT pretty fast, but that's not the investigation of choice, but that's what a lot of people end up getting these days. Things hopefully should get better a little bit once the new MRI in Abbotsford starts, hopefully in October.
Thank you. There's a question from Dr. Burns, Ken. Is TENS appropriate in low back pain, TENS machine?
Yes, it is appropriate. We always encourage, you don't have any side effects from physical treatments, right? So TENS machine, massage, all these come under physical treatments. And, whatever works for the patient, it doesn't work for everyone, but even if it, reduces the pain by 5%, and if your Tylenol and Advil reduce your pain by 10%, they all add up, right? So whatever helps the patient is fine. TENS does work by the gate theory, which is basically a distraction theory. And some of the older patients do find benefit from TENS machines. So it doesn't seem to be working so well in younger patients because I think their expectations are higher.
Are there any contraindication for TENS, especially peripheral neuropathy or diabetes?
No, there's no contraindication for TENS.
Even with people with peripheral neuropathy with diabetes can use the TENS machine?
Yes.
Thank you. Okay, there is a comment from Dr. Patterson saying there's quite good choosing wisely pamphlet for patients explaining when the imaging is inappropriate or when it is appropriate.
Yeah, we're going to share it a bit later tonight. A link to this resource. And then if anyone would like printouts, it will be also in the survey. As part of a radiology project, we can provide clinics some printouts. Any other questions, Dr. George or Dr. Raghavan?
We still got about 10 minutes. Guys, if you want to ask, this is the time and chance for your questions to this specialist.
So I can tell a few things about the back pain project. One of the challenges that we are likely to face from the back pain project is, if we identify the candidates for urgent imaging, where do we go for this imaging? Um, when the wait list is so long, then there should be a mechanism by which we can fast track some select patients for urgent imaging. So I think we'll have to have the discussion with the Ridge Meadows radiology group to see if they can, you know, come up with some idea for select patients in their coverage.
Unfortunately, that's not going to happen. So we already had some heads up from them. So if all the GPs locally, they stop referring patients for MRI rather than they refer to the back pain clinic, and the back pain clinic is the one which triages. And if they deem somebody needs an MRI, and then they go into central waiting time. So if the MRI burden, waiting burden is reduced in Ridge Meadows Hospital, people from the other areas like Langley, Surrey, Delta, those people will be allocated those MRI slots in Ridge Meadows Hospital. So they will be taken up. So that is something disappointing, but I think, yes, I agree with you, Dr. Arvind. We need to uh, sit with these people, Ridge Meadows or maybe central office, and see we have to be prioritized because we're reducing the referral numbers, and whoever is referred, they're genuine and they need to be scanned or imaged on a urgent basis or expedited basis. Would that answer your question?
Yes. So no, that's true. But it gets filled by patients from elsewhere.
That's
I
correct.
mean, it's not just elsewhere, right? Like we do a lot of Ridge Meadows patients in Mission. I think about 60% of our Mission patients are from Ridge Meadows. So I don't think we should have regional barriers. Whatever, that's an advantage with central booking that people can at least get in wherever they can, right? So I don't think we should be protecting our hospitals that way. If all of us reduce our unnecessary referrals, it will help everybody, right? And Rich Meadows can scan patients who need other parts of their body imaged by us doing less lumbar spines. So I don't think we should go that way. And of course, if and there was a question about Cauda equina here. Cauda equina, I think if anybody calls us, we try to do it within 24 hours. That's the mandate for health authority for Cauda equina. It's a P1 and has to be done within 24 hours. And CT doesn't really have a role. I think it's just very rarely will CT help and often might cause false reassurance. So I wouldn't do a CT in a Cauda equina.
I have one question suggestion / suggestion. So see patients who have been waiting for 6 weeks, conservative management, radicular symptoms, and we know that they may benefit from a scan. Is there, like, at least for the Ridge Meadows area, if we decide, the GPs decide we are not doing unnecessary referrals, we are cutting down, referrals are only through pain clinic, is there a way to allocate some slots which, like on a weekly basis, which are reserved for patients coming from chronic pain referrals for MRIs, so that if there are patients fine, they get the slot. If they're not, then they fill up with other stuff like from other areas, whatever those slots are there.
So I don't work here, so I can't comment on that.
Well,
But
it's not for you.
No. What I'm saying is, though, these are all P3 patients. They all will go automatically to central booking. So I don't think the local departments can, sort of do those sort of things. But I mean, yeah, you'll have to talk with your local department there. But most of these patients are triaged as P3 and they all go to central booking.
And nowadays, how much time does it take for a lumbar spine scan for disc?
So I just asked my tech, and he says 6 to 8 months.
No, I'm talking about the time of this, like
Or
duration.
the scan.
Yeah.
So in an older scanner, it takes about 45-50 minutes, but with newer scanners, 25 minutes. Like, we don't even need 5 or 6 sequences. We do 3 sequences, and less than 20 minutes now we can do these scans. But the problem is, like I said, Abbotsford is in a trailer, right? So there's the number of scanners available are few. A lot of hospitals still have very old scanners. So those things take time. But the newer scanners can scan in 20-25 minutes.
Dr. Mawani, you want to ask your questions? Shiraz?
I've indicated on my chat.
Yeah.
So, Dr. Mawani, the triaging, we have something called e-triage where everything is electronic and the radiologist triage all the MRIs. So if there is a clear history, if you say caudai equina, we triage it as P1 and they should be done within 24 hours. P2 is, when it's not caudai equina but significant enough, those are supposed to be done within a week. But other than the machine shortage, we also do have technologist shortages. So those would be some of the factors which, sometimes often we don't meet these windows because of that.
Thank you.
But if you make a call, if somebody picks up a call and tells me, this patient needs urgent imaging, somehow or the other, we do get the scan done. Often it means canceling somebody else, but what can we do?
Thank you.
There's a question from Dr. Kelly, Laura Kelly. If it is true caudai equina, I would say most of them, some of it's caused by tumor, which may be treated with radiation, not the surgery. And Dr. Patterson, how often patients with symptoms of caudai equina actually treated with surgery? How often? I think it's an emergency. They should all be treated. Any neurosurgeon, Dr. Nanda, you want to answer that question?
Please repeat again.
How often are patients with symptoms of caudai equina actually treated with surgery?
So I can tell you one thing, and probably Dr. George will agree with me. Even if patient presents to ER with caudai equina symptoms, and it looks frank caudai equina symptom-wise, there is no way to tell without scan if there is actual caudai equina compression. And on the other side of the spectrum is that sometimes patients do present with mild symptoms, not very severe symptoms, or you suspect, and they have a big full-blown disc. This is my experience. So to answer your question, if patient presents with caudai equina symptoms, you send the patient to ER, that patient is scanned, and there is a disc, then the argument is to take the disc out as soon as possible, provided the symptoms are not established for more than 72 hours. If the symptoms are like a week long and there's a caudai equina compression disc there, then it's not done as an emergency, then they schedule it for next day or whatever. Otherwise, it's done overnight.
Would that answer your question, Kathy?
So if the symptoms are new, not established, there are symptoms, there is a disc on the scan, patients are operated overnight. Whenever the patient presents, the next available slot will be given to them. So if the patients present with symptoms which are more than 72 hours long, even if there's a disc, then they will be scheduled for the next day. If the patients present with symptoms, there's a disc, but there is still not full compression, well, then it's plus minus, depends.
Thank you. So one last question. I don't know whether we are the only neurosurgeon here, Pankaj. You need to answer this question as well. I have few patients. This question is from Trisha Patidar, the physiotherapist. I have few patients coming in saying they're on the wait list for ultra minimally invasive lower back pain surgery, TLIF. That is just starting in Canada later this year. Could you elaborate on this surgery procedure? When will they start in BC? I think this is the last question. We're running out of time. And after that, we'll have some poll questions. Pankaj.
So TLIF is a fusion process, basically. So we put rods through stab incisions. So whatever used to be open surgery, like big incision, and put rods on two sides and join them, or screws on two sides and join them with the rods, is basically like stabilizing fusion surgery. So TLIF is the minimally invasive. So instead of a big incision, you put like two stab incision on two sides of the spine, like paramedian, and then slide rods through and join the screws. That's a TLIF. I don't know about the Canadian system, when it is available, when it's starting. I have no idea. I haven't worked as a neurosurgeon here, and I won't be working as a neurosurgeon here.
Okay, thank you. Thank you, Dr. Raghavan. Thank you, Reena. And thank you, everyone. Thank you for all your questions. And I hope we learned a few things, especially regarding imaging and how unnecessary is imaging an acute back pain in the first 6 weeks without any red flag symptoms, which we know already, but to coming from the specialist to reiterate and reassure us not to do any unnecessary imaging, that's great. And you want to...
Yeah, I just want to mention that we are going to share the slide deck and resources in our next Sunday e-news. And we also have two patient-facing resources for low back pain and headaches. You can see the links in the chat.